right, we are going to get started today. I'd like to welcome you to the Oral Cancer Prevention webinar. My name is Jennifer Estes, and I'm with Baylor Scott & White Health, and we are so happy that you are here for this event. I do want to go over a few housekeeping items with you. So for the event today, we are going to be sharing a brief video, and then we will have plenty of time left to do Q&A with our expert panel. And if you are on the panel, if you want to go ahead and turn on your video camera and your microphone, that would be wonderful. I will introduce you here in just a moment. For the Q&A, there is on your dashboard a questions section, and that's where you can put your questions. I will tell you, since we have such a large group, we're not sure we will get to every question. However, for any questions that we don't cover in this event, we are going to take those to our clinical experts, and we will collect all the answers, and we will send that back out to you. So you will get the information that you need and that you are asking for. Also, I wanted to let you know that you should have received a pre-test. Sorry, I know this is not school, but the reason that we do the pre-test and the post-test is that this cancer prevention event is part of our Commission on Cancer accreditation process. And that is a national standardization to ensure quality, coordinated cancer care. And so we want to be sure that we are really putting information out there that helps you learn what you need to know to take care of your health. So if you get the test, please take it so we will know how we're doing. I also want to let you know that following this event, we will have in-person oral cancer screenings at various sites, and we will send you information about those screenings and how you can register for those after the event. So we've got a lot of information that we will be following up with you on, and we would encourage you to take advantage of those free oral cancer screenings at our various sites. And with that, I see that we have 3 of our speakers on camera, and I know Dr. McNamara is here with us as well, so I will introduce him last so he has time to get his camera on. So we will start with Dr. Jerry Barker, and if you'll just wave so everyone knows that it's you. And I want to share that Dr. Barker, born and raised in Texas, he graduated from Abilene Christian University in 1993 and from UT Southwestern Medical School in 1997. His residency in radiation oncology was at the University of Iowa and the University of Washington in Seattle. He finished in 2002. He was a fellow in head and neck radiation oncology at MD Anderson Cancer Center through 2003. Dr. Barker is board certified in both radiation oncology and hospice and palliative medicine. His professional interests include treatment of head and neck cancer and palliative supportive care for very sick patients. He is married, and he and his wife have 2 children and live in Fort Worth. So thank you, Dr. Barker, for being here.
Thank you.
And we have Dr. William McNamara with us. So Dr. McNamara, if you'll wave at the crowd here, that would be wonderful. And I will share your bio. We're so happy you're here with us. Dr. William McNamara is board certified in surgery, and he completed his fellowship training in head and neck surgical oncology at Memorial Sloan Kettering Cancer Center, one of the nation's premier cancer treatment institutes, under the direction of world authorities in head and neck cancer treatment and reconstruction. He has a special interest in minimally invasive surgery and robotics. An important goal of Dr. McNamara's is to provide patients with advanced surgical care for head and neck cancer with an emphasis on quality of life issues, such as retaining functional abilities and normal appearance. He works closely with a highly skilled team to create individualized treatment plans that keep curing cancer as the main goal. Welcome, Dr. McNamara. And then finally, we have Erin Flemings. She is a nurse navigator. She has been a registered nurse for 42 years, so I know she must have started when she was just a child. She's been certified as an oncology certified nurse since 1993. So she has been doing this a long time. She's worked in a variety of settings, both inpatient and outpatient, in 4 states in the Southwest and across the East Coast. She's been involved in research of cancer treatments, medical and radiation oncology, and surgery and endoscopy. She coordinates support services for patients with all cancer diagnoses in the Patient Resource Center. She believes providing education is a significant contribution to a patient's toolbox. She says helping the patient understand the meaning of their diagnosis, treatment plan, and next steps are the core basis of a patient navigator. So we are so thrilled to have such an expert panel. We do have a very brief video that we want to show you, and this has 10 things that you need to know about oral cancer with Dr. Barker. And then we also have, as part of that video, a patient, Mr. Lyles, who faced oral cancer and has just a very inspiring story to share. And so we want to show this brief video. It's about 15 minutes long, and that leaves us plenty of information for Q&A with our experts after the video. So with that, we will kick off the video, and the speakers, we will turn off our cameras.
My name is Dr. Jerry Barker. I am a radiation oncologist with Baylor Scott & White All Saints Medical Center, Fort Worth. And I have been asked to tell you 10 things that I know about oral cavity cancers, but let's start with a story. So I want to tell you the story of a patient named Betty, who is 68 years old. And she tells me that she has been smoking her whole life. She says that she has smoked since she was very young, really didn't feel the need to stop. She tells me that even the doctors were smoking back then, but her primary care physician continued to bug her about her cigarette smoking. So about 25 years ago, she finally kicked the habit. She then tells me that nothing really happened after that, so she thought she was okay, even from the smoking she had had before. But then, very recently, she says that she noticed a little sore on the side of her tongue. And she went to her primary care physician, who was concerned and referred her to an ear, nose, and throat doctor who did a biopsy, and sure enough, it showed a small cancer. So she had surgery for the cancer. They removed the tumor with a small bit of tongue. Fortunately, it was caught very early, and this early stage cancer didn't need any more treatment besides just the surgery. And she's cured, and she's happy, and she's really thankful that she found the tumor when she did. I think that story illustrates very well what life can be like for some of our patients with oral cancers. Now, let's spend some time talking about 10 things that I know about oral cancers. Well, number one, let's start by talking about just the term oral cancer, because the term itself is a little bit confusing. Doctors usually use the term oral cancer in 2 different ways. There are cancers of the mouth, so things like the tongue and the lips and the cheeks and the gums. We call those oral cavity cancers. And then there are cancers behind the mouth in what we call the oropharynx. These are structures like the tonsils and the very far back or base of the tongue. Now that seems like kind of a small semantics, picky issue, but it's actually really important because these 2 different parts of the body, the oral cavity and the oropharynx, have 2 completely different kinds of cancers. That leads us to number 2 and number 3 on our list of 10 things to know. Number 2, most oral cavity or mouth cancers occur in people who smoke or who have smoked in the past. Now, a lot of us don't really think much about smoking anymore, at least not in the United States, because so many people have stopped smoking over the last several decades. In fact, in 1955, almost half of all adults in the United States smoked cigarettes. But today, that has dropped to less than 15%. Many of us don't really think about smoking or smoking-related cancers as much anymore. But having smoked in the past is still a risk factor for having an oral cancer today. And believe it or not, there's still 30 million adults in the United States who smoke today. And these oral cavity cancers are usually related to smoking. That's different from the oropharynx cancers. So that takes us to number 3. Oropharynx cancers, the throat cancers, like base of tongue and tonsil cancers, most of those cancers are not caused by smoking any longer. They used to be in the past, but now most of those cancers are caused by a virus known as HPV, or the human papillomavirus. This is a virus that has been experiencing an epidemic across the world for the last several decades. We didn't even realize it was happening until the 1990s, but it is unfortunately happening with increasing frequency. And today, most adults worldwide have had an exposure or an infection with HPV by the time they're in their teens or 20s. So it's a huge part of the world's population that's been exposed to HPV. And for some reason, a small number of patients actually develop throat cancer because of that old infection that they had when they were younger. It's not many people that make cancer after that infection, but there's so many people in the world that have been infected that quite a number of patients each year have oropharynx cancers. So although the oral cavity or mouth cancers are on the decline as smoking decreases, unfortunately, the oropharynx cancers or the throat cancers are on the increase. Well, number 4, some patients will get oral cavity or oropharynx cancers for reasons other than tobacco use or HPV infection. So for example, some patients can get these cancers because of secondhand smoke exposure, or because of pollution, like air pollution, or perhaps because of chronic irritation. And sometimes doctors are just surprised that there doesn't seem to be a clear reason for why a patient may have developed one of these oral cavity or oropharynx cancers. Number 5, these cancers are not rare. So it's estimated that this year, approximately 500,000 men and women will develop oral cancers. That's about 55,000 in the United States alone. Interestingly, and for reasons we have never fully understood, more than twice as many men will get oral cancers than women. So these cancers are very common. Well, number 6, interestingly, most oral cavity and oropharynx cancers are just one histology of cancer, one type of cancer, and that is called squamous cell carcinoma. So squamous cell carcinomas are cancers of a lining, in this case, the lining of the mouth and the throat. Patients smoke, the smoke and the carcinogens in the smoke affect the lining of the mouth. And when the HPV virus infects, it infects the lining of the throat. So most of these cancers are lining-related cancers and are squamous cell carcinomas. It's interesting because that's not true in many other parts of the body, where you can get a cancer, but it can be one of several different kinds. With oral cancers, it's usually squamous cell carcinoma. Well, number 7, oral cancers can be prevented. That's good news. First of all, if you don't ever smoke, you have already dramatically reduced your risk of developing an oral cavity cancer. But even for smokers, stopping smoking is associated with a significant reduction in the risk of developing an oral cavity cancer. So those are easy ways to avoid mouth and throat cancers. One other new way to prevent the throat cancers is HPV vaccination. So it turns out that the virus that causes these throat cancers can be prevented, and there are vaccines available now to do just that. These vaccines have been proven to be safe and very effective at preventing infection with HPV and the subsequent cancers that HPV can cause. These vaccines are available now to adults, teens and adults all the way up to age 45. And that is a powerful way to reduce the risk of developing these cancers. Number 8, if you can't prevent an oral cancer, you can at least find it early. That's important because finding one of these cancers early means it's more curable. The cure rate is higher the earlier the cancer is found. One way to find these cancers early involves a general principle that I like to tell my patients is just a good principle of life. There are certain things that can happen with your health that are just never normal. They may not be cancer, but they deserve to have a doctor's evaluation. And some of these apply to head and neck or oral cancers. So for example, a sore in the mouth that just isn't going away, or spitting up or coughing up of blood, or new pain in the mouth or throat that doesn't stop, or a lump in the neck that doesn't go away after a few days. These things may not be oral cancer, but they do deserve to have a formal evaluation because it's too easy for us to make certain that it's not a cancer. There's one other important way to find oral cavity cancers early, and that's to screen for them. So every year in this community, we have screening events where patients who are at high risk, like current or former smokers, or patients who aren't at high risk, are able to go and have a doctor evaluate their mouth and make sure that they don't see any cancerous or precancerous lesions that are of concern. So stay tuned for screening events in your immediate community. Number 9, what do I do if I am diagnosed with an oral cancer? It turns out there are very effective treatments for oral cancers. For oral cavity cancers, the treatment is usually surgery to remove the cancer and a small area of tissue right around the cancer. When found early, that alone is curative. For the oropharynx cancers or the throat cancers, it's a bit more common that we would use radiation or chemotherapy to try to cure those cancers without needing surgery. And the good news is that when any of these cancers are found early, the cure rate for early stage oral cancer is about 85%. So when found early, these treatments are highly effective and most patients can be cured. And that brings us to number 10. Survivors of oral cavity cancers can have excellent quality of life. So particularly when these cancers are found small and early and the treatment can be the least, these patients can live normal lives with very little in the way of side effects from their treatments. And that's good news. All right, well, that's 10 things that I know about oral cancers that I've been able to share with you. So let's summarize. Oral cancers can be avoided, like with smoking cessation or HPV vaccination. They can be found early by patients reporting symptoms quickly or by screening. They can be treated with things like surgery and radiation therapy and chemotherapy. They can be cured with excellent quality of life. And for those patients who are cured, their lives can go on normally.
Hi, I'm James Lyles. I'm 57 years old. I'm the father of two beautiful girls. Met my future bride, Donna Hayden. So we got married. I moved to Fayetteville, Arkansas, where I was for about the last 26 years. Had just been on a vacation. She had mentioned that she had a small bump in her breast. I remember feeling it. And it was a very aggressive, and it already metastasized, and so we were immediately pretty deep in the hole as far as getting her well. We've always just held out hope that, she was going to beat this thing, and then lost her 9 months later on May 11th. I just knew that, despite the grieving, the pain, I got to be there for my girls. So I just made it a mission to do that. I loved living in Fayetteville, Arkansas, and I had a lot of friends, but I have all my family in the Dallas area. We moved in August. At one point in time, I felt this little thing in my throat, but it was so minuscule, I didn't think much about it. It just felt like there was something caught there. But a couple of weeks later, I just developed this horrendous sore throat. So I went to a walk-in clinic in Southlake and gave me a steroid shot to help me maybe swallow and eat. I decided, a couple of days after that, I'm going to look down my throat. Well, I opened my mouth and looked, and there it was. So I talked with my sister, and she recommended an ENT, and we immediately do a biopsy. And sure enough, he called and confirmed that it was. And I thought, all right, well, it's just, we got to fight it. So now we've got everything in order. We've got the plan in place. I did get my 35 treatments. And I ended up having to get 2 more chemo treatments. And then all of a sudden, for whatever reason, it just got to where I couldn't eat. That ended up going for 15 weeks. All the while, it's in the middle of basketball season. I just made a point that, I'm never going to miss a game. She played 38 games, and I missed one only because I had to have a treatment. I wanted to try to maintain as normal of an existence as I could. I just wanted her to know that, I'm still her dad. I'll never forget that last day, and I wanted to celebrate in some way, but I was weak. I was tired. I went from 240 pounds to 176 pounds. That last treatment was sometime, I want to say maybe early December. I guess it might have been in close to February. I asked my daughter what she wanted to eat, and she said, do we have any salmon? And I thought, you know what? I think I got a couple of salmon steaks in the freezer. We'll do that. I guess instinctively, I just was telling myself, I want to eat so bad. Stuck a fork in that salmon, put it in my mouth, and slowly started to chew, and the thing actually went down. I thought, man, what a mild victory. I've had my first meal in 15 weeks. It's now that hopefully is behind us. The magic window, I guess, is 5 years. So when, they're going to continue to see me, and after 5 years, if I'm, there's no evidence or any markings of any cancer, then I'm home free. Right now I'm in just a really good spot. I'm close to my family. They've been a wonderful resource. Both my girls are doing exceptionally well. I feel good. I actually been playing some golf. I hadn't played in probably 3 years, and my goal was just to make a round of 18, and I was able to do that. So I guess it's time to start living again.
And I probably should have suggested that you might need some Kleenex when you watch the video. I know I did. So his story is just so inspiring. So we've already had quite a few questions come in. So if our expert panelists want to get back on camera, we will just kick it right off. And we'll start with you. I'd like to start with you, Dr. McNamara. And the question is, How are head and neck cancers typically treated, and how do you decide on what treatment options are best for a particular patient?
So can you all hear me?
Yes, sir.
Okay. Well, the treatment, I mean, it's kind of a little bit described already by Dr. Barker in that nice video, but the treatment for head and neck cancer, initial treatment is usually specific to the area of the head and neck that the tumor arises from. Tumors in the oral cavity, for the most part, they have not spread significantly yet, and they can be resected. They're treated with surgery first. And then we call adjuvant or treatment after surgery with either a radiation and or chemotherapy based on the aggressiveness of the tumor and the stage of the tumor as decided from the pathology report. Cancers of the oral pharynx, like we just heard about, and the tonsils and the tongue base, there's multiple ways that these can be treated, and a lot of them are based on how early the patient presents. Tonsil cancers that are HPV related, there's equal efficacy in terms of standard first line treatment with surgery plus or minus radiation or radiation and or chemotherapy. We usually reserve surgery for these patients on early cancers. So where we would do is called, a radical tonsillectomy or a tone-based resection to remove the tumor and then take out the lymph nodes and the portion of the neck in order to assess them for spread of disease, whether it be gross disease initially or microscopic disease. Now, candidates for surgery are usually ones that we feel that will do well afterwards without significant morbidity to their swallowing or to their speech. If the tumor is too large, or if there's too much extensive node disease already and they would already need chemotherapy and radiation, then surgery is usually not for those patients, and we would just proceed with upfront chemotherapy and radiation. For patients that don't want surgery either, like I said before, there's equal efficacy. You can have radiation upfront and or chemotherapy based on your stage of disease at the time of diagnosis. Other types of head and neck cancer that are more rare and kind of less prevalent, salivary gland cancers are again usually treated with surgery up front, and then with radiation if it's more advanced. Okay, larynx cancer is the throat cancer with the voice box. For the most part, we try and treat that non-surgically up front if we can, just to preserve the voice, okay, and the function of the larynx. It's kind of a general overview, but that's the start of it.
That's very helpful. Thank you. And so it sounds like it's just very specific to each patient and what they're facing and what their desires are going forward.
Correct. Yes.
So that's very helpful. Dr. Barker, I have a question for you. We've had several questions about the HPV vaccine, kind of what that is, why you should have it, and when you should have it. And someone specifically asked, is it available for patients who are older, say older than 45? So if you could just talk about the HPV vaccine, that would be really helpful.
Great questions. So we're very fortunate over the last several years to have vaccines that are available for human papillomavirus. They were originally designed to prevent infections that lead to cervical cancer, but we have several reasons to believe that they would equally reduce the rates of some of these head and neck cancers as well. So they may actually work to prevent quite a number of different cancers that are HPV related. And so there's multiple reasons to think about getting an HPV vaccine. HPV causes some benign tumors as well. So a variety of rationales for getting vaccinated. I think the key to vaccination is you have to beat the virus to the person in order for the vaccine to work. So, most of the time our flu seasons are in the winter, and so sort of in the fall we start thinking about vaccinating for that. Same thing is true with HPV, only most of the world's population is exposed to HPV by the time they're in their late teens or 20s. So that means the target audience for HPV is younger than that. So like younger teens, these vaccines are authorized by the FDA for use starting at age 9, actually. A lot of pediatricians are having these conversations with parents kind of right around the time that these kids are becoming adolescents. That's a very common time to start a series of injections for HPV vaccination.
So it's typically younger patients because you want to get the vaccine before they would be exposed. So it may not be helpful if you're over 45.
That's right. So that's a confusing issue because recently, if you've been following in the news, the FDA actually increased the ages at which folks can go and get these shots. So although I think it's ideal for very young folks to get HPV vaccines, it may still have efficacy later in life. Another way to say it is that it turns out there's dozens or even more than 100 types of HPV virus, and the vaccines protect against several of those most aggressive types that lead to cancer. So even if I'm in my 20s or 30s, maybe I've already been exposed to some types of HPV, but probably not all types of HPV. So right now, the FDA says that anybody up to, I think it's age 45, is a fine candidate for vaccination. So even if you're in your 20s or 30s or 40s, it may not be too late, and it may be a good conversation to have with your primary care doctor.
Great. Erin, this question is for you. What is the role of the nurse navigator in helping patients through a cancer diagnosis and treatment, and is there any cost for that?
Okay, well, when someone has a diagnosis of cancer, thinks they may have a diagnosis of cancer, one of the first things that they feel is a feeling of powerlessness. They don't know where to go. They don't know who to talk to. There's coordination of care, as you've seen. You have to see an oncologist, you see radiation oncologist, you see a surgeon. And so helping coordinate all of those offices together and helping the patient understand their treatment plan and the goal of that plan is what a navigator does. We can also help them coordinate throughout the continuum, and we follow them from the point of diagnosis through treatment, and in survivorship, we follow them completely through and continue to follow them, encouraging them for follow-up treatments, keep your scans, keep your appointments, things like that. We help them with, after the initial diagnosis, we are an ear in case they're frustrated, they identify barriers to care, and we help them take care of those issues. Our services, you can refer yourself or you can be referred from a friend or from a physician's office, and our services are free of charge.
That's wonderful. Thank you. So you just walk alongside them and you're there to be that helping hand and listening ear. That's
absolutely
wonderful. Dr. McNamara, this one is for you. It's kind of a two-part question. What are some of the potential side effects of treatment and how long do they last? And then one of the specific questions related to that was, can oral cancer cause speech disorder or speech loss, and how common is that? So just in general, what are some of the side effects and how long do they last and how do you manage that?
So given the area that we're working on with the cancers, of course, they're very sensitive areas to areas that you use every day regarding speech, swallowing your own saliva, eating. For the most part, oral cavity cancer is the upfront, treatment is surgical resection. So the best outcomes are for surgical resection. So based on the extent of disease up front, the patient can have morbidity afterwards. And we usually try to mitigate that. A lot of times if a large amount of tissue is necessary to remove, we rebuild or reconstruct the area of the oral cavity with plastic surgery in terms of restoring volume to your tongue so that we try and maintain speech as best to your pre-cancer abilities as possible, as well as eating. If it's in the bone, we reconstruct the bone with a piece of bone from the leg that goes to the jaw to maintain facial contour and less morbidity with that one, but also possible swallowing, but more of its kind of cosmetic nature. And too, if it's in the back of the throat, the oropharynx, where the tonsil on the tongue, the base of the tongue is very susceptible to morbidity from our treatments, whether it be radiation or surgery. But like we said earlier, we don't partake in surgery if we think that the morbidity from the procedure, okay, will cause significant swallowing problems or speech problems afterwards. But we know that the patient could have acceptable treatment with the same outcome with radiation and or chemotherapy. Dr. Barker can attest to this more, but radiation does cause significant problems during treatment, and sometimes, for a long time afterwards, with regards to swallowing as a result of pain and scarring, as well as decreasing in saliva production in the mouth, and then temporary loss of taste. So as the patient in the video explained, that during treatment, surgery, radiation, and chemotherapy during treatment is a very difficult process for head and neck cancer, when compared to a lot of other cancers in terms of the day-to-day morbidity that patients will ensue. So when we try and come up with treatment plans, usually a lot of it's based on, large evidence-based data and cancer guidelines on how to best treatment in order to get the best survival outcome and reduce chance of recurrence. We do take into account the morbidity the patient will undergo based on the treatment, if there's other treatments that are as effective.
Well, and it just makes me think of what you shared in your bio about you really try to look at maintaining their functional ability and their appearance, and you take all of those things into account with the goal of curing the cancer, but you consider all of those factors. So you're really looking at the whole person.
Correct.
Dr. Barker, I think this question would be for you. We've had a lot of different variations of this question come in, but people are asking about tobacco and oral cancer. So someone said they smoked for 25 years, but they stopped smoking over 15 years ago and want to know if they're still at risk. There are also questions related to smokeless tobacco and vaping and how those interact with oral cancer or potentially cause oral cancer. So could you kind of address the tobacco issue?
Great questions. So congratulations for quitting. That's really honestly probably one of the most important things you can do for your health. So that's fantastic. And I would encourage anybody listening who is still smoking to do anything that they can to try to stop. Active smokers certainly have the highest risk of developing cancer. Stopping smoking doesn't completely eliminate all risk. So unfortunately, we still see patients who quit many years before and still have cancers that develop, but it radically reduces the risk of developing additional cancer. So definitely want to stop smoking. I would say the same thing about oral tobacco or about vaping. I mean, I think any use of nicotine, any use of tobacco carries some risk of danger. I definitely think that, when patients who have smoked for a long time use something like vaping to try to stop using cigarettes, that's probably an improvement in their risk. But the only way to get to zero risk is to stop using nicotine or tobacco products altogether. So that's certainly what oncologists would vote for. And we would encourage you to talk with your primary care doctor or others about how to do that. That's critically important for your health. Great question.
And a follow-up question that I think would probably be a good fit for you, Aaron. If someone has tried to stop smoking several times, do you have any suggested resources to help them stop smoking or stop using smokeless tobacco or other products?
The primary thing is to encourage them as much as possible and support them through that decision. We can refer them, we have smoking cessation information, getting them together with a counselor who can help them with strategies. So yes, absolutely. Encouraging them to stop and then supporting them through that decision.
So there are resources available to help
There are.
if you need that.
Yes.
Dr. McNamara, can you talk a little bit about any of the advances you've seen in treatment in recent years and and the hope for people who are facing an oral cancer diagnosis?
So we have a lot of advances in terms of surgery, I guess, in the past, I would say 15 to 20 years. One probably being the most is the use of minimally invasive transoral robotic surgery if we were to undergo upfront surgical resection for the HPV tumors, mainly in the tonsil, the base of tongue, and sometimes we use the robot for larynx procedures as well. But it allows us, in the past, you would have make an incision in the jaw in order to be able to access that space, given the fact that it's in a deep area of the throat that you just can't get your hands into. And then the robot now allows us to do that up front. The other area that's more improved is that definitely as we go with time, there's more and more improvement in plastic reconstruction and how we can put the tissues and the form of the face back together without significant disfigurement compared to what it used to be 20 years ago, 20, 30 years ago, which allows us to restore cosmesis as well as function to the best of our ability. And then I think those surgeries are definitely getting better and better, where a lot of times in the past, patients would have had significant dysfunction in terms of swallowing, speech, and or cosmetic outcomes that they were not happy with that affected their overall everyday life. So those are probably the two biggest ones. We also have Dr. Barker can attest to this more, but the advances in radiation with the new use of proton irradiation has allowed reduction in the amount of side effects and long-term side effects that we see in patients that require radiation after surgery or in lieu of surgery for initial treatment.
So it sounds like we're just getting more and more precise in being able to target those cancers.
That's
which is
correct.
really wonderful for patients. Dr. Barker, I think this one would be for you. If I have a symptom and I'm concerned it might be oral cancer, or I've found a sore in my mouth, what's my first step? Do I go to my primary care doctor? Do I go to the dentist? Do I go to an oncologist, an ENT? Where do I start that process of determining if this is a more serious issue?
A lot of folks will go to a dentist or a primary care doctor, and I think there's a lot of skill in our community with dental professionals and primary care physicians in trying to sort out which problems are really ones to worry about and follow up on more, and which problems are benign and maybe something to keep an eye on but don't really need more treatment. I would definitely encourage folks, though, that if there is a problem in the head and neck that is not going away, particularly if it seems like it's getting worse, it's never wrong to see an otolaryngologist or an ear, nose, throat doctor for those kind of problems. And unfortunately, sometimes we see patients who have, really waited or not pursued some symptoms for a while, or maybe their doctor, really didn't think it was much concern, and it turns out it really is cancer that's growing. So, as I suggested earlier, something that's new and different and not going away, it may not be cancer, but it probably deserves to be evaluated. There's some things in life that are just not normal, and we talked about that in the video. I think that's good advice.
Excellent advice. Somebody asked the question about their dentist offers the enhanced oral screening for $20 and it's not covered by insurance, and they just want to know if it's worth paying that extra money for that enhanced screening, or should they be able to detect oral cancer just by looking around my mouth? And that would be for just whoever would like to address that.
I'll jump in and say, every time I go to the dentist, there's something new. That's just something about dentists. They're amazing that way. Not all of these things that are being promoted to try to find cancer early have all been shown to be home runs. But some of the tools are getting more and more clever, and there are some new tools coming out that even dentists may use to try to identify oral cancers sooner. So I recognize that some of these things have some cost associated with it. So that's always kind of an independent decision, a personal decision. But fortunately, just looking in your mouth is free. And so if I look in the mirror or feel something in my neck or have some new symptom that isn't going away, that I can take action on without even having to pay for a screening test.
Dr. McNamara, did you have something you wanted to add to that?
Yeah, I mean, the only thing to add is a lot of those cancer screenings, they're looking, kind of using, something associated with chemiluminescence to look at the gums in your mouth. So a lot of times you might get this, they might find a lesion that they see that's kind of questionable, but there's no lesion in the mouth. Okay, there's nothing that looks abnormal. There's nothing that's causing a symptom. It might be even in a person that doesn't have a tobacco risk. The problem is we don't have any data to support anything to do about that. I mean, if I don't see it, if it doesn't look abnormal to me, I wouldn't even biopsy it. So maybe it gives you a heads up to focus on an area in the future. But it's not completely applicable yet, just because there's no data to demonstrate its effectiveness, and then how you treat it thereafter. Like Dr. Parker said, the best thing is just physical exam and correlate symptoms to what you see in the mouth, and doesn't need a biopsy.
And I will just give a plug that we are in October. We're offering free oral cancer screenings at several different locations in Dallas, in Irving, and Fort Worth. And so you will get a communication after the event, and you can sign up for one of those if you would like to take advantage of those free oral cancer screenings. You will need to register for that, but we'd love for you to join us. Erin, this question is for you or anybody. What type of alternative or complementary therapies are used in addition to traditional medical treatment to help oral cancer patients, or are there any?
I think I would defer to one of the physicians.
I'll jump on that one. There are definitely things that some of our patients tell us are helpful, along with the standard cancer treatments that Dr. McNamara and I have been talking about. What comes quickly to mind, some of our patients really find benefit from things like massage or acupuncture. Not necessarily things that all patients would want to pursue, but I've seen some patients derive real benefit either in just anxiety and stress management. I've seen some patients use acupuncture after treatment, for example, to help with dry mouth. So there's actually a variety of things that are available. We use a fair number of over-the-counter medicines to help our cancer survivors as well. You would think that with an army of cancer survivors who have consistent problems like dry mouth and trouble swallowing, there might be some super awesome prescription medications that can help with some of those symptoms. For a lot of them, there aren't. And patients kind of exchange recipes of different over-the-counter things, but some of those can be really helpful in ameliorating some of their symptoms. So I would throw that out as things that I've seen a number of times.
Erin?
So in the support groups, when we have oral head and neck cancer support groups, the patients all get together and they do share ideas. The primary side effect that we hear about is dry mouth. The radiation affects this area. And so they come in, they say, okay, I don't make saliva anymore. There are preparations that you can buy over the counter that they recommend that will help moisture collect inside the mouth to help them eat better. There are preparations that you can add while you're eating to help moisten the food to help you swallow it. And they are very, very knowledgeable about those things, and they share those with each other. Some of them work really, really well depending on the chemotherapy or the infusion that you had in conjunction with your radiation. A lot of patients will talk about there are little lozenges or troches that you can put in your mouth, but if you don't make saliva, they get really sticky and it makes your mouth sticky. So they share those things with each other, and I would encourage anyone who's going through treatment for oral head and neck cancer, chemotherapy and or radiation, along with surgery, because sometimes that affects the muscles that help you swallow. They have a wealth of information to help you with those side effects and help you combat those.
That's great. Thank you. And Dr. McNamara, do you have anything to add as far as can treatment-related side effects be managed, and anything that you've seen be really helpful in that regard?
I mean, the biggest thing that I use or recommend, or what I've heard the patients kind of respond the most to, is definitely, the massage therapy, whether it be with physical therapy or whether it be with a lymphedema massage specialist, or, regular massage to help loosen the muscles in the neck after any scarring that forms from surgery and or radiation. And even over time after they finish treatment, this is shown to be beneficial. The saliva problem is definitely pretty significant in almost all head and neck cancer patients. There hasn't been any one thing that I've seen that's great, so it's kind of what the patient finds that works for them, and we give them a bunch of recommendations, and they're all over the counter. But what works for one patient doesn't necessarily work for the another patient, so it's kind of trial and error.
Yeah. Well, we're almost wrapping up our time, and so I just wanted to give each one of you a chance to share a few last words. Anything you want to share, or if you maybe specifically want to just share why you got into this and what you find most rewarding about the work that you do in working with patients facing cancer. So if each of you just wants to give a few last words, we would love to hear that. Dr. Barker, you want to?
Sure, I'll start off. Thanks, Jennifer. Well, first, thank you for putting this all together. I think it was a great presentation. And, one observation I would make is that although we made the point that there are a lot of people that have oral cavity or oropharynx cancers in the United States and around the world, it's not the most common cancers. So there is still, we have a lot of work to do to educate our neighbors and friends about head and neck cancer. And those of you who are listening to this today can help be a part of that. We've had kind of some mixed messaging, for example, about HPV vaccination in the past, but now you can really see, I think, that there's some real value to that in preventing the kind of cancers that require tough treatment to get past. And then, we can always remind our family and our friends about the values of stopping smoking. So you guys can be our messengers leaving this presentation today, and we would really value the help. Thanks for being part of this.
Absolutely. Sharing that information with the people you love is very beneficial. Dr. McNamara, do you want to give a few parting thoughts?
Thank you, Ken, for being part of the panel. It's great. But I mean, I think the biggest thing to take away for the general public is if you start developing symptoms that don't go away, like we said earlier, is to get it looked at. Head and neck cancer is the best results, the best overall chance of survival is to catch it early. So don't sit on it. If you think something's wrong, just have it looked at. If you still think something's wrong and you're not happy with that answer, have somebody else look at it. Just because to let it go and to let it progress, affects outcomes significantly. So I think that's aside from, I think, at this point, you don't have to tell people not to smoke anymore, but it's true. Sometimes you do, but tobacco use, if you just cut it out, we wouldn't have a lot of these in the first place. But I think the biggest thing is not to sit on it.
Well, I think that's such an excellent point, and that's really what our Mr. Lyles in the video shared, that he had something he just thought wasn't right and went one place, and they said, oh yeah, we'll just give you the steroid shot, but he just knew something wasn't right, and especially with his experience with his wife, and he just said, I've got to get this, I've got to get an answer on this. So you have to trust that, just like what you're saying. So, and Erin, would you like to just share a last thought with our audience?
I'm very passionate about cancer care. I lost both of my parents to cancer, my brother. I've been in cancer treatment for a long time. I've seen huge improvements with cancer treatment, fewer side effects, not as severe. What my role is to help you understand the diagnosis and not be afraid of it, but to understand what's coming, help you understand those expectations, manage them, and be available should you need anything.
Well, and that's so wonderful, Erin. So you took something that was very sad for you and you've turned it around to help all these other people through your role as a navigator. Well, I just would like to thank all of our panel, Dr. Barker, Dr. McNamara, and Erin, for taking the time to do this and sharing your expertise. I think this was very valuable information. I also want to thank our audience for joining us here today. You are the reason why we do this, and we are so appreciative of you giving your time for this. And please share this information with your friends and family, and we will just all work together to take care of our health and take care of one another. So again, thank you all for being here. Thank you to our panel, and I hope everyone has a great day. Thank you.